to pick your brain about thyroid. Hypothetically, what is that TSH? If you can just run through one or two of those cases and then just put some numbers into it.
So we always start with the TSH, right? Baseline. Hopefully, if the patient have hypothyroidism at baseline, you still have to adjust the drug. And those patients are at higher risk of having thyroid dysfunction, right? Because they have low reserve. So you initially, let's say baseline, 2.69. Actually, a patient from today in the morning, 2.69. Everything looks good. First dose of Pembro, nothing happens. Second dose of Pembro, TSH comes to 0.01. And then you're like, let me get the T4. So the T4 is elevated. Don't remember the top of my head the exact number. It's elevated. And you're like, well, you're in thyroiditis now. We have to let you cool down. But you don't treat it at least the patient is symptomatic. If the patient is symptomatic in the thyroiditis phase, you do have to do propranolol. You do have to do the inhibition, but then we have very close follow-up. At that point, I do call my endocrinologist because there's a very fine line when the patient is hyperthyroid and then become hypothyroid, right? But if they're symptomatic and because it's so hard to get patients to endocrinology because there's no enough of them, I sometimes start the propranolol. Then an average is between 3 and 9 weeks. Then the TSH starts rising. We check TSH at that time every week. Every week is overkill. Every 2 to every 3 weeks. It's the half life of the hormone. And you will see the TSH going from 0.01 to 3, 6, 10 is the cutoff by the guidelines. And that's when we start the levothyroxine. And you can see subsequently how the T4 goes down. But you will notice the T4 goes down is slower than the TSH. So you should follow the TSH to transition from the hyperthyroid state to the hypothyroid state. And it's a very fine balance. And you need to remind the patients to take their pills too.
Thank you so much. That was so helpful. Um, I love the complementary medicine. Anyways, I'm just curious, how do you then tease out, like, oh, this is complementary medicine LFT elevation versus um, immune checkpoint inhibitor adverse?
So I had a patient that we were doing neoadjuvant therapy. So this is a curative intent because immune checkpoint inhibitors are also approved in the neoadjuvant setting in lung cancer. So I had this patient and I'm like, okay, the elevator. These are the liver function tests. And I start my interrogation, and the patient and the wife will say, no, no. It's like, okay, well, we may have to start steroids and propose the surgery because hepatitis panel is negative. There is no other cause. And my patients are so comfortable because part of my culture is complementary medicine. And I make them very normal in my clinic so they can talk to me because a lot of complementary medicine is awful because patients don't feel comfortable. And then I say, if you have started something, go home, look at it. If you find something new, send a picture, send it to the patient portal. Boom. When they go home, they remember. And it was a tea. It was a root-based tea that somebody brought from Taiwan that has these mushrooms that are dry. And when you hydrate them, they actually affect the cytochrome enzymes. And then what we did is we are like, no more complementary medicine, no more immunotherapy. Let's see how your liver behaves in 2 weeks. And so that we saw the liver improving. And then we're like, well, we have a confounding factor or bigger goals to get you to surgery are going to re-challenge you because we can re-challenge patients with immune-related adverse events. Grade 1 and grade 2 are most likely to be re-challenged in the future. So I didn't start here on steroids. So hepatitis induced by immune checkpoint inhibitors doesn't get better on their own because that monoclonal antibodies stays in target for a very, very long time. We have data that this immunotherapy can stay in target for up to 9 months from the last dose. And patients can have immune related adverse event. This is a very good point, even after they stop getting the drug, right? After, because that monoclonal antibody is still there, your T cells are still active. So that's how I discovered it. And his liver enzymes went back to normal in 2 weeks. I gave him more doses of immunotherapy, and he went to surgery. Now I barely see him, but hopefully he hasn't started anything new. But it is important to talk about it. And I open the door and I give them a brochure that I wrote with the Lung Cancer Research Foundation during the first visits So they know that I'm game for that. And I have articles about cannabis, and I just wrote an arrow one about cannabis and cancer. So, and I have a box of lubricant, vaginal lubricants in my clinic. They know that we talk about anything in my clinic. So that really helps because sometimes they just don't feel comfortable, or they feel like, oh, the doctor is going to get angry at me. So I open the door because I get it.
I'd love to jump into a case of pneumonitis. So, this is a case for Mr. Johnson, 64-year-old male, history of HFpEF, IPF, stage 3 non small cell lung cancer, diagnosed 2 years ago. He has been receiving atezolizumab as a part of his treatment plan for the past 10 months. He presents to clinic with a dry cough, shortness of breath, and chest discomfort for the last 4 weeks. And then on exam, he is satting 93 on room air. Some crackles are heard in the lower lung field. How would you approach the diagnosis in this case?
So the first thing is a diagnosis of exclusion in a patient. I have a lot of questions about the treatment decisions for this patient, but we're not gonna end that as a lung cancer doctor, as a TSO. So the first thing is he has heart failure, right? So you need common things are common. We see more heart failure than pneumonitis, right? But like my teacher in internal medicine used to say, don't get blind by the zebras. Common things are common, right? Because everybody likes the zebras. So is this a heart failure exacerbation? Is this a COPD exacerbation that you need to take into account? The COPD exacerbation is very hard, but the good thing is the treatment is the same for the pneumonitis and COPD exacerbation. Imaging is going to be your best friend. So no chest X-ray. In this case, we skip that. We go straight to CT chest, and the inflammation pattern will help you understand. If it's a diffuse groundglass, a diffuse infiltrates in both lobes, that's a drug-induced pneumonitis, right? If it's a COPD exacerbation, you wouldn't see this kind of fussiness all over the CT scan. So the CT will really help you. Who should get admitted in pneumonitis? If the patient is not hypoxic, doesn't really qualifies for admission. So you can treat these patients as an outpatient, and I treat them with antibiotics and steroids. That's the ASCO guidelines for pneumonitis. And it tends to be also the same treatment for COPD exacerbation. The only thing is that the steroids tend to be a more prolonged course. Because the goal criteria used to be is 5 days for COPD exacerbation, right? That's what you do now only. Yeah, pneumonitis is 6 weeks. So, but the difference between the COPD exacerbation and the pneumonitis is that they get like a Lazarus effect. You start the patient in prednisone, and next day you call them and like, doctor, I'm doing great, doing great. So you don't get that with COPD. It takes a little bit longer. It's a T cell mediating process, and you have to do 1 milligram to 2 milligrams of prednisone per kilogram. So it is a more hefty dose than the dose for COPD. But you don't want to miss an pneumonitis. I ask my patients to also get a pulse ox to be checked. If the patient is hypoxic, though, that requires admission. And that's pretty much the break off. Because I have patients with diffuse infiltrates and the CT chest, and they have 98%. That's a grade 1 because they're not symptomatic. The symptoms is what makes it a grade 2 to grade 3. So you have to admit them. When patient gets admitted, pulmonology should be called to do a BAL to rule out any infectious source. And also, some data coming from the University of Colorado and Hopkins shows that you may find a difference. A lot of high T cell infiltrates, a lot of mast cells, a lot of neutrophils. You may see them in the BEL. But the problem with the BEL is that it's also, not super accurate. I never had come with a BEL. It's like, yeah. It's always like suggested off, right? But hypoxia is the reason for admission and rule out any other cause.
So it's interesting that they do antibiotics and steroids.
It's because there's a high risk that you may missing something else. A lot of these
Yeah,
patients are in chemotherapy, and that's the guidelines I show that it's safer to start
right.
antibiotics. If you are certain that's pneumonitis, like I have patients that are 41-year-old, never, no tobacco users, no COPD, like their lungs, this just bad luck. They have lung cancer. Then my probability to start antibiotics is low, but I still do it because the risk is too high. But one thing about steroids that you mentioned is rapid titration, no pneumonitis, all immune related adverse events. Rapid titration of steroids produces a rebound. So that's why the titration needs to be slow and based on results. But pneumonitis tends to be a lot based on symptoms and pulse ox and CT findings take a while to get better. But other things like liver function tests, you will see a rapid decrease. You need to keep them in a slow taper because otherwise we have rebound transaminitis. And that's very important because the rebound is harder to treat than the initial one. And of course, when the steroids don't work, you may have to get a TNF inhibitor. But we need to be very careful. TNF inhibitors should not be used for hepatitis. They're very good for colitis, but for hepatitis induced by immunotherapy can actually worsen the course. So TNF inhibitors, if somebody needs a TNF inhibitor, I would recommend that they call the specialist because you don't want to use the TNF inhibitor in the wrong patient.
Yeah, definitely. That's good to know. What about the patients who had prior radiation before they're on immune checkpoint inhibitor, um, and the CT is just hard to interpret?
So, so there's actually a lot of research in trying to use proteomics to differentiate between radiation-induced pneumonitis and immune checkpoint-induced pneumonitis. The main thing we have is location. So we immune checkpoint inhibitors a diffuse inflammation, both lungs, upper lobe, lower lobe, middle lobe, everywhere. For radiation tends to be we in the radiation field. So that's what helps us differentiate. But sometimes there is no a clear picture. There is a whole thing of research of developing new imaging, dynamic imaging that will help you understand why is the reason. And this patient that you presented, Anu, he got radiation as a stage three,
Mhm.
right? So he potentially has radiation fibrosis now, 10 months, but initially he had radiation pneumonitis. It's very common. So it's a very fine line. But we do know that the patients still alive for 5 years are the ones that were able to get all the immunotherapy. This is why I think is a very good take home message is if you identify these immune-related adverse events early, it allows for the patient to maybe re-challenge in the future. Because if you identify as a grade one or grade two, you can re-challenge. But if it's a grade three or grade four, that's a no-no. So it's very important. And for patients that have autoimmune diseases, we didn't even touch about that, which is so common, particularly populations of color. So populations of color were not included in the immunotherapy trials. People like me, Black, African Americans, Native Americans were not included, but around 1 to 2% of patients were of color. But we know that autoimmune diseases are significantly larger in populations of color. So all of these patients were excluded from the trials. First, the populations of color were excluded, and the patients with autoimmune diseases. So now we're trying to use these drugs in these patients, but a lot of it is like, you know, makes you nervous. So those patients with autoimmune diseases depends on the autoimmune disease, right? Hashimoto's, they're gonna get it with immunotherapy or without it. So we're good there. But like a no-no is myasthenia gravis, multiple sclerosis, very active lupus with any end organ damage. But then there are those patients in the middle, like temporal arteritis, so not very active rheumatoid arthritis. But we know that any history of autoimmune disease increases the chances of immune-related adverse events because that disbalance already exists, and those T cells are already like no liking normal tissue. So you turning off the off switch, it's just like releasing the water gates for patients with autoimmune disease. But that doesn't mean they shouldn't get it. So they should have very good discussion and risk over benefits. And it's a big gamble because you know that some of these patients can get cured with immunotherapy.
So I think we have time for probably one more case. So this is about Miss Moon, had a history of stage 4 metastatic melanoma, which was diagnosed 3 years ago and has been undergoing treatment with Keytruda for the past 18 months. She presented to the hospital with acute on chronic abdominal pain, nausea, vomiting, diarrhea, inability to tolerate PO. And then a CT showed duodenitis and diverticulitis. She was started on antibiotics and still wasn't getting better. So, what is your approach to this diagnosis, and like when do you start thinking about ICI colitis in the differential?
Well, the first thing is that she's not getting better, right? I have to reiterate the patient history makes such a big difference, right? Did you have diverticulitis before? Did you have vasoverticulitis before, right? So, what the patient was before the cancer diagnosis matters a lot. So in this case that you're presenting, that she didn't get it better with antibiotics as an indication. Also, it looks like you did a CT. Let's look at the wall of the colon. Something that's very unique to colitis induced by immunotherapy is they have wall edema, and you can see that. In diverticulitis, you see the pouches that are inflamed, but they're individual. But here is a continuous wall edema, and it's a malabsorption diarrhea. That's what it is. It's like Crohn induced by drugs. So it's a malabsorption or that diarrhea. And the patient will tell you, very different than the diverticulitis diarrhea, is how did they say it in their own words? Everything just goes through me. That's a very common phrase because the wall has so much edema because there's T cell infiltration that produces this humongous amount of inflammation. So there is no way that there is any villi able to absorb anything. What I'm surprised here is that the patient has duodenitis. Still can happen, but that means the patient has symptoms for quite some time. Because usually we see colitis before we saw inflammation of the small intestine. Doesn't mean it cannot happen because with immunotherapy, anything is possible. So I call the radiologist, like, talk to me about the wall. And they will tell you the wall has a lot of edema. The patient says everything is going through them. The antibiotics didn't help. The timeline with the immunotherapy makes sense. There is nobody else sick at home. Because another thing that will give you malabsorption is these goodies that people get from like the kids from school, or if they went to a cruise. Number one differential diagnosis for colitis is like, did you come for a cruise? Because Nova can give you horrible diarrhea. But the point is, all these points here you have not getting better, the findings in the CT scan, the timing will be enough to treat this patient with steroids. But most important, these patients need to get maximum supportive care because they can get very dehydrated and very weak. In these patients with colitis, there is also a very fine line of when to scope. When do you scope? It all depends on the CT scan. Because if you use scope when there is a grade 3, you have a risk of rupture. So you need to be very careful that the patient has stabilized a little bit before you go and put a scope in. Because compared to the lung, when you have a trachea, with cartilage, you have a colon that's literally all blown up and it's like a balloon. So colonoscopies or sigmoidoscopies are recommended, but the patients need to cool down for a little bit, a few days. And in medicine, that's actually how it works. Not because it's on purpose, it's just because the bleeding team is in a bleeding case. And then the colonoscopy, the sigmoid gets scheduled for the next day. So the patient already has 24-hour steroids. But we have to be careful that they don't get scoped right away. And if the patient doesn't get better with steroids, these patients will get better in 3 to 5 days. Then you need to follow closely to see if you need infliximab.
Yeah, that's a really helpful framework. And one thing that we ran into was this fact that ICI colitis resembles Crohn's, and you see this here with like sort of like these skip lesions and this duodenitis and diverticulitis as well. So you mentioned infliximab as therapy for higher grade toxicities. Are there any other therapeutics that are considered?
Yeah, so it's just a reminder of all your immunosuppressant transplant drugs. So infliximab can be dangerous for the liver, so we use Celset. When the steroids don't work, we use Celset. We use tacrolimus. So why we reject that organ is the same thing of what we produce immune-related adverse events. There's to be a lot of cell-mediated. So Celset, uh, tacrolimus emission, infliximab, but it's all organ dependent. And when you get to these higher drugs, it's time to call the specialist, the organ specialist, especially for liver. Like, I don't feel comfortable prescribing tacrolimus. Like, I give a lot of immunotherapy, a variable immunotherapy, but as soon as the steroids are not working, I call my friendly hepatologist. Um, so we use those. Sometimes hydrochloroquine is also used. It depends on what is the organ and what you think, the data is out there. That would be safe. But steroids, like I say, nobody should die without the benefit of steroids.
I love that. With the fatigue, nausea, all that you mentioned earlier, do you ever stop um, immune checkpoint inhibitors because of that, or how do you kind of what would you want an internist to know about kind of management of that?
If the fatigue is affecting the patient's quality of life, you need to rule out things that you can fix. And that's adrenal insufficiency 101 because it can sneak like that. So I do a cortisol stimulation test. And of course, I take the TSH. And men, take testosterone because high immune checkpoint inhibitors can also cause hypogonadism, in the which testosterone can be unmeasurable and that can cause fatigue. So you always exclude any immune related adverse events. And the fatigue by the drug becomes the exclusion criteria. So in the trials, any patient that was in prednisone less than 10 milligrams was allowed. So sometimes you use some palliative steroids, very low dose to keep these patients because the inflammation can be so large that the inflammation itself produces the fatigue. So as long as below 10 milligrams of prednisone, it has not been in the current data related to worse outcomes and lung cancer. So sometimes I put these patients very early and low dose steroids to decrease the inflammation that the drug is producing so they can keep getting the drug. But I rule out everything else. And honestly, I validate fatigue. And that's what I think every doctor I get to meet is validate your patient's symptoms because sometimes patients with cancer have fatigue and they're in part gaslighted and say, of course you have cancer, you should be fatigued. No, like how bad is this fatigue? You don't want to play with your grandkids like you used to do? That is a problem. You are not, and of course, depression. You need to rule out depression, right? Don't get excited by the zebras. Don't forget they're dealing with metastatic cancer or with cancer, period. So when all of that is ruled out, sometimes I put patients in very low dose of prednisone to help with the inflammation, and eventually I titrate them off. But that's a possibility.
That's
But it
excellent.
should be validated.
I love that. One small question about the colitis. You mentioned like the timeline for the pneumonitis and the skin. Like, for the colitis, is there a usual timeline, or it can also just happen anytime?
So for colitis, I think this is coming from my memory. It can happen from cycle 2 or above, so 6 weeks or moving forward.
Cycle is every 3 weeks.
Depends on the drug.
Oh, okay.
So right now, most patients get pembrolizumab when it comes to lung cancer. So the drugs have been approved sequentially. So melanoma was the first one, right? The Davida oncology book used to say, not all cancers are as bad as melanoma. Now that has to be rewritten because now we have patients that the cancer melts away with immunotherapy. So pembrolizumab has 75% of the market because it was a study in these cancers that didn't have good treatment. So melanoma, lung cancer, right? Nothing really worked there. Triple negative breast cancer, bladder cancer. So that's what the drug owns so much of the market because there was such a big need. And there has been subsequent approvals, but something about oncology is that you will learn is we're persons of habit. So if you are using Pembro for the longest time, that's the one you're going to use. So Pembro tends to be every 3 weeks. Durvalumab, Durva, tends to be every 4 weeks. Nivolumab is every 2 weeks. Atezolizumab is every 3 weeks. And if you use ipilimumab, we haven't even talked about CTLA4 inhibitors because those are the ones that give you all the immune-related adverse events. The dosing can be every 3 or every 6 weeks. And during the pandemic, we got approval for pembrolizumab every 6 weeks. Not a big fan, it produces a lot of fatigue, but some patients that live in northern Maine want that, and that's okay. They don't want to come to Boston. But the dosing goes from 2 weeks to 6 weeks.